All right, good morning. Happy Friday, and welcome to another Extracorporeal Hour. I'm Dr. Cedric Dufayet. I'm the head of the hemodialysis unit for UC Davis in San Diego. And I'm co-hosting those rounds with Dr. Jethro Forbes.
Hey folks, Jethro Forbes from Cornell, directing our extracorporeal therapies and blood purification units, and coming here every other week to learn along with you guys, pick up some tips and tricks from what other folks are doing, and to really hopefully spread the collective growth of these therapies to do a better job and to learn what other cool stuff you guys are up to.
Be sure to mention about Renal Week coming this coming spring, when there would be lots of opportunities to learn about extracorporeal therapies and hands-on laboratories.
I'm just pulling up the
Yeah, I
dates.
realize. So dates are from April 12th to April 17th, if I'm correct. There will be a hemodialysis boot camp with a lot of hands-on labs, I guess at the beginning of the week, followed by 3 days of lectures and more labs in the afternoon, I guess. So yeah, week of April 12th until April 17th, 2027. Probably should make a nice slide to announce it for next rounds. But yeah, I'm kind of excited. Guess the whole team in Washington is putting up a nice program for us all, so it's gonna be cool.
So I guess in
And
the
a
interim,
nice
those that information's on the acvnu.org website.
for sure. And it's also a very nice social event. Let's face it.
And fun this year. They invited Cedric and myself to host a couple of sessions of the extracorporeal hour and a half. We might have to rename it since it's a 90-minute session. So we'll have a couple of live episodes, if you will, meetings, roundtable of sorts. We're still working on some of the format and how that's going to come together. But essentially, it'll be based off of this Zoom format, but with all of us hopefully face to face and in person, which is going to make the discussion even more lively, hopefully, and more interactive, which will be a lot of fun. And also, as Cedric said, and Dr. Calga, just a great opportunity to see some of these friendly faces and to collaborate, to meet, to connect while learning about all the great ways we can get better with extracorporeal therapies.
And speaking of new faces, like if anybody wants to turn on their camera and introduce themselves, see a couple new names in the participants. So please, if you want, you can come forward, tell us where you're from, what you're doing in extracorporeal therapies, or what you want to do in the future, and just get to know each other. And then we'll see if we have any topic coming up.
I don't know. Serena, have we had a chance to meet you?
Hi, everybody. I'm from Italy. We work with a nine people team in an ICU that perform also dialysis therapies such as plasma exchange, also CVV, HD, F, or EHD, but in a very small part of our patients. So that's pretty tall.
Oh, great. Well, thanks for joining us. If you've got some interesting cases or questions or challenges that have come up in your practice, it sounds like you guys must be with a 9-person team in the ICU, a fairly busy practice. How is your caseload these days?
Actually, we have about 35 cases per year. In this period, in this very period, it's not so busy ICU talking about renal replacement therapy, but we work a lot with other kind of patients. Maybe the moment is not the best. So I haven't any recent case, unfortunately.
Well, that's all right. We look forward to hearing about your cases as they come up as we get to know you a little bit in these every other week sessions. That's great to have you all the way from Italy. Thanks for joining today. And I see Carolyn on there. Carolyn, are you coming to brag about the your recent patient that you sent me a picture of?
I don't know that I'm going to brag. Unfortunately, our patient passed.
Oh
Yeah.
no.
Yeah, we treated on Tuesday morning, I guess. Our large animal hospital got in touch with us. Kriya had been born, found out in the pasture, I think about 5 or 6 in the morning. So, this was probably about 9:30, 10 in the morning. They contacted me. She was super septic. Let me see if I can send the picture to my. She was super septic, and unfortunately, we did an 8-hour treatment with her, doing hemoadsorption with a vet rescue column just for circuit size. We treated her on the Revive pump with a small circuit set and a small cytosorb column, vet rescue column. We did 8 hours of therapy. By the end of the session, she was nursing, and I'll have to, I can try and transfer the pictures to my computer and show them to you in a bit. But by the end of the session, she was nursing. She took a bottle really readily. She was super coagulopathic. Her TEG was really hypo. Her starting ACT timed out. Her ACTs we never got a read on her ACT. She always timed out. However, probably about an hour, hour and a half into the session, I noticed that my column pressure increased, and I fed basically I fed the column like just a tiny bit of heparin. I gave it 5 units per kilo based on the Kriya's weight, and my pressures went back down, allowed us to finish our 8-hour session on her. The next morning, she was still nursing, doing really well, was able to thermoregulate better. However, on fast exam, they noticed that she had a little pericardial effusion. Um, they also saw that she had pneumonia, not unexpectedly. But then subsequently in the afternoon, she got an echocardiogram. They didn't see anything really abnormal other than the pericardial effusion, mild pericardial effusion. She, I guess, took a bottle after the echocardiogram, and then shortly thereafter passed very suddenly. So we did get pre and post samples on her, and we got a 12-hour post sample on her. So we'll see what that says. But um, based on the samples from our calf, we didn't see really dramatic kind of ending date changes in cytokine. Oh, there it is.
Oops, sorry about that.
Oh,
There it is. Trying to get
oh,
it.
that's the picture I sent Dr. Forbes. That's our Kriya getting treatment. Um, by the end of the session, she was picking up her head, like I said, and nursing. Um, but based on the data from the calf that we treated, we were just wondering, we'll be really interested to see your data, Jethro, um, on whether or not what we're doing is just decreasing the overall burden that they're having. Like, because during the session, it doesn't really look like we're reducing their cytokine load that much, but I'm just wondering if, on day one, everybody has a certain burden and then we treat them and their overall load will go down. It'd be interesting to see what their cytokines are day 2, day 3 in comparison to maybe a calf or a cria that's treated medically.
Yeah, that I think that comparison to the medically treated patients will be an interesting one to try and tease out some of that
Caroline,
benefit.
is your strategy just to treat once, or and does that or did you treat more than once? And does it make sense that one session, just like a TPE session, is going to fix everything that's broken?
We weren't sure. Um, you know, th we had planned on kind of going forward depending upon where she was, but she was looking really, really good. And so with her ACT still being really prolonged, um, they wanted to wait at least a day and see how she recovered. The calf that we treated at the beginning of the year, it made such great, remarkable improvements by day two, by the second day that we never really felt we needed to treat her again. And the Kriya was looking a lot better, and so we had kind of decided to hold off on a second treatment. We were also at the tail end of a really, really rough Memorial Day weekend. Um, we were treating, I think we had 5 patients in the hospital we were treating. So it was kind of a rough weekend. So we were like, if she can take a break and we can take a break for a day, we wanted to kind of give her the day and give ourselves the day.
And I think Dr. Cowgill's question is something we've been struggling a little bit with as well in our clinical cases. We had a couple of foals. One was a septic foal, and one was became septic, but was a dummy foal. So we were treating for had arrested at birth at parturition, and so we were trying to reduce cytokine burden in that foal. What we learned from, well, here, let me go ahead and share while we're here. Sorry, I'm just going to try and bring this guy up here. This was our 2-day-old mini horse that came into us septic, failure to nurse when born, and so did not have passive immune transfer. Had a pneumonia, had every clinical indication of being septic, from the hypotension, tachycardia, elevated lactate, fibrinogen, the whole deal. And so this was one that we only ended up treating one time, as this was our first foray into the large animal species, or alternative to dog and cat species. And it was some of our collaboration with Callie Hobbs and some of the other folks that have been doing some of the ex vivo work on cytokine removal, was what promoted our interest in helping this horse out. And I'm fortunate to have partnered up with Barbara Delvescovo at Cornell, who's a large animal criticalist and internist, and has a real growing passion for these therapies and the species that she helps out. So she helped fund our treatment on this guy, and that's the other part of the challenge here, is the cost slash funding. Because a lot of these guys come in without a lot of the resources to do a whole lot. So we're finding middle grounds to help these guys out. But this was our first foray into a clinical patient. As you can see, all of those things, and in this one we did place an 11.5 French. She was 10 kilograms. And we placed that 11.5 French catheter and brought her into our small animal unit, similar to, I think, where you were treating the Kriya, I think there, Carolyn. And for this horse, we only had the capacity, the availability, and some of the funds to treat the one time. So it was a one and done for her, and just some interesting ways that we applied our monitoring devices onto the little base of her hoofs there to get our ECGs going. And we used Purify pump and the Vet Rescue device. And this was, at least for this particular patient, these were the TNF alpha and IL-10 levels at baseline 30 minutes. And this patient we only treated for just over 2 hours. We didn't go as long as Carolyn and the Tufts team did. And when we look at some of the other cytokines, not quite as robust of a drop in this patient compared to the TNF alpha and IL-10. So interesting anyway, which did drop. Unfortunately, we don't have levels from the following day, but clinically after the treatment, And actually during the treatment, she, went from laying lateral, flat, hypotensive, and really quite down and out to we actually had to work on a little bit of cuddling with her, keeping her on the table and keeping all the monitoring and the catheter and the blood lines happy. So at least from a clinical perspective, similar to what Carolyn was describing there, we definitely saw improvements during the course of the treatment and the following day as well. She was still looking pretty strong. And herein from this case, this is where I wish we would have treated a second time. Back to Dr. Calgill's question and what we're learning here, because she did take a turn. She looked good the following day, so we held off for a number of reasons, and finances were certainly part of that. And the following day, she developed multiple septic joints, and the owner had, even if we had paid for the hemoperfusion and cytokine removal, they were not able to continue hospitalization and had exhausted their finances, and she was deteriorating significantly enough. So I think, when we looked at her, I really wish we would have treated on that second day, had we had the capacity. We had a discussion on it. She seemed to be improving clinically. Do we just go based on that? Do we still need to give her more of a reset, a cleaning, if you will, so that she can continue to be supported medically and have the best chance? And so looking back on that, our experience with this septic foal certainly informs our next patients in terms of the multiple treatments, not just the single treatment, even though, again, it wasn't practical for this patient to have a second treatment for a number of reasons.
Yeah, and I think if you look at the graph that you just showed us, it may seem like after like 30 minutes, nothing much is happening, right? Um, After that initial drop at 30 minutes, like your values like look a little flat. And that's why it would be interesting to get like a post-treatment 6-12 hours after treatment value. Because we might very well see those value like spike again. And maybe that curve looks flat just because you're kind of removing as much as is generated. And it's not that you're not removing anything. It's just like it's kind of like equilibrates with what's generated. And being on treatment allows those cytokines to be low. But if we stop the treatment, they might go back up to baseline. And that's gonna one we need to see. I mean, it was my understanding that in people, when they use the cytosol for sepsis, they tend to do a more continuous therapy, with like keeping like the cartridge on the circuit for like 24, 48 hours. I mean, they exchange cartridges, but they keep the patient on absorption continuously for at least like 48 hours. So, I mean, may not be practical to do in vet medicine, but very similarly to what we do with therapeutic plasma exchange, maybe that daily treatments and maybe 6-8 hour treatments daily might allow us to remove the burden. And if they're improving and the generation of cytokines is going down with medical therapy, we might be able to discontinue after a few days or go to every other day or something like that. But um, I mean, we go back to the fact that when we do these treatments, we really need to sample and accumulate data so we have a better understanding of the course of the disease. And just like Caroline was mentioning too, it's like it would be interesting to compare with medically treated patients and see if patients with hemoabsorption have a more favorable course of disease in terms of timing to improvement or even outcome. So comment in the chat. Yeah, Becky says that at MedVet New Orleans, they had numerous 24-hour treatments. Yeah. But did you get good outcomes though, even if you don't have like numbers or data to show? Yeah.
Yeah, sorry. I'm actually in the process of moving from New Orleans to Philadelphia. So we did get some good outcomes. It's really hard for me to commit to saying like, yeah, I really think we helped this patient when I don't necessarily have any of the data. There's a couple that I remember that like there's one I remember that we did because we thought he was just really Sursy after like a ruptured splenic mass. He got a 24-hour treatment and did great. It was like a 12-year-old mixed breed, like bully kind of dog. But I feel like they always make us look good. He truly seemed like he was on death's door. And like as far as vitals, I do remember around hour 16, we were able to discontinue pressure support, like norepi. And I don't think we had anything else going on. I think we were able to discontinue some like dextrose or something too. This was a few years ago. And then another one that we did that I remember is a dog that had lymphoma, a golden retriever. I think he'd had it previously, was in remission, had started having seizures and had lymphoma again. We did, I think, 24-hour treatments on him. And to my knowledge, that dog is still alive and kicking. It was a golden retriever. I think he was 12 years old at the time, maybe a little bit younger. But yeah, he did really well. There's other dogs that we, had that didn't do great. We had a heat stroke dog that I remember. I don't know if it's because we didn't start soon enough or because it just wasn't going to help, but she didn't make it. Unfortunately, she arrested while on the circuit. And then I know of another one that got into a whole bag of joint supplements, like flavored like joint supplements. She got, I think, 3 24-hour treatments and unfortunately arrested during the last treatment. So it's definitely a mixed bag. I think that chemo, I kind of wonder if you would have.
And Becky, during those extended treatments, were you changing out the devices or
Oh
same
yeah,
device?
we changed them at 12 hours, usually, unless for some of them, if we were like thinking that it was getting completely saturated with like bilirubin and we just weren't clearing enough, because we would just check on the Nova. We would switch maybe sooner, but if we got to the point where we were going through more than 2 devices in a treatment, we would just stop the treatment after that device was finished up, because we didn't want to like charge people almost $1,000 for multiple devices in one treatment per device. So we would give them basically a day off. Usually if we did a 24-hour treatment, we would do 24 hours, a day off, and then get started again after that next day off.
Cool. Well, I think that's I think some of those experiences, that's exactly why these meetings are so great to share some of that, both the clinical, whether there's levels or not, using bilirubin. It sounds like you're using bilirubin as a marker to try and help determine if it was time to change out device in the column. That's an interesting tool to use, and I certainly use that in a clinical case, an IMHA case that I also had an absorptive device in circuit with, and I was measuring bilirubin pre and post to try and find that same sweet spot. Where were we at equilibrium? When was it time to change out the device? So I think that's an interesting marker that we do have, other than some of these other cytokines and other markers that might not be available bedside to make in the moment clinical decisions. But saving some of those lab results to try and inform the next treatment, or to try and inform how the rest of us practice as well. So that's really interesting stuff.
Yeah, we had some samples saved. When I had gone back to the hospital a few months ago, because I started at UPenn in October, but when I went back to get some more things from the city, I made sure that they sent some of our samples from the plasma freezer to Parker. So I don't know if he got them. I don't know if they've been able to do anything with them, but I'm so curious.
One of the comments that come up, and maybe Parker or Jeff could comment on this as well, but perhaps using a solute like bilirubin as a surrogate for cytokine equilibrium or saturation is not going to be justified, because those solutes are bilirubin be at an orders of magnitude greater in concentration, and and where you're talking about cytokines, I mean, the concentrations are so little that it's likely that maybe the device never saturates for those solutes, and you could do an extended treatment on a single device. Maybe Parker or Jeff have any thoughts on that?
Yeah, I agree. Bilirubin, pretty small molecule versus cytokines, which are order of magnitude larger. You could easily saturate the device for bilirubin, but not saturate the device for cytokines. Yeah, I don't know that there's much correlation between those. I think
Well,
certainly,
I wasn't thinking so much the size of the molecule, but the magnitude of the concentrations. Is that what you
well,
meant?
that too, because of the concentration, we're talking nanograms. Even in a severe inflammatory situation, you're really talking about nanograms of cytokines versus a much larger concentration or volume of bilirubin. So I probably not a good marker for cytokine, but certainly clinically very relevant. Looking at bilirubin removal in those patients is certainly relevant.
Yeah, when we were deciding whether or not to switch out, we would still finish a 24-hour treatment with that device. We wouldn't switch it out because we weren't necessarily using it as a surrogate at bilirubin for cytokines, but if we were trying to clear bilirubin and we had just kind of either saturated or plateaued on how much we were going to actually get, from the vascular space, we just decided we wouldn't switch again. We'd only ever switch one time for a treatment.
Yeah, and I agree, with what you guys are saying. In fact, I remember the cases down in New Orleans. Unfortunately, those samples were so old that I actually told the site that we wouldn't be able to analyze those at the time. So I don't believe they have them anymore. But yeah, I remember the case, and what I remember particularly about the pity case is when asking if they followed the same protocol that we do on the human side, whereas you on the first day you do every 12 hours, second day 24 hours, and then potentially a third day 24 hours, constantly clinically evaluating the patients. I asked the vet that was there at the time, did she switch out the device? And she said no, and the reason being is that the patients just kept getting better. And so there was no need to. So I think, in the absence of, a good marker that you guys can, assess in a rapid fashion, in the example of cytokines, a lot of it goes back to the assessment of the patient. How are they responding? On the careful part with, doing a 6, 8, or even 124-hour treatment, once you stop treating with one of the devices that's out on the market, the biggest risk is because the body is still producing cytokines, and while the device is on therapy, it's taking them off just continuously. Well, if it's not taking them off and they're still in that pro-inflammatory state, you're going to have a buildup and you can see rebounds. So I think the clinical assessment is critical throughout this process to ensure that you're treating the patient on therapy if they need it, and moving forward accordingly.
Well, I think, yeah, I agree that looking at the patient, is always important, and I think that's what has guided some of our other clinical cases as well. Our second septic foal, well, the dummy foal that had arrested and then ultimately did actually become septic as well. We treated multiple days sequentially. Overcoming our reluctance. Well, she looks better this day on day 2 after our first treatment, so maybe we could hold off a day. We overcame that based on our experience with the previous foal, and it kind of hits on Carolyn's description of the Kriya as well. Even though there was some clinical improvements, we decided to go ahead and treat day 2 and then a third day as well, although we added in a day off in there also. And that case, where we collected some samples from, and we still have some analysis to do in terms of cytokines and other markers. But we took rather than waiting and saying, hey, she looks better, let's not do another treatment. We actually went ahead and performed the subsequent treatment. And one of the these really sick patients, and I think Carolyn had mentioned the reluctance of the team because her coagulopathy was still a concern. I certainly feel that as an obstacle to another extracorporeal treatment, and the mindset of, hey, we also don't want to do harm by taking this blood outside of this patient and running it through the extracorporeal system. But my sense, just personally opinion, and based on a couple of the small clinical cases that we've done on the large animal side anyway, is that subsequent treatments and repeating them, even if they do look a little bit better, seems to be what the pattern that we're going to implement while we gather data and we gather markers to try and get something under the surface to back up that clinical improvement as well. So it's a little bit of a combo.
And I wonder if, because obviously we don't get the cytokine levels in real time, so you can't really look at the rebound and decide if you want to treat again, like we would do with urea or creatinine dialysis patient. But for intermittent treatment, I wonder if we could use some over-surrogate marker of systemic inflammation, like CRP, for example, and just document that the CRP is still very elevated, so it may be worth treating again today. Or if the CRP is greatly improved, you might be able to hold off and wait another 24 hours or something like this. Because CRP is more and more available at bedside now, point of care. So I mean, just I've been using it, for example, in IMHA patients before TP sessions, and I mean clearly the patients that are improving, usually you see a pretty significant improvement in their CRP as well. And I would occasionally, after the first 3 treatments, when you get to that day 4, day 5 of a disease and the PCV is holding and you wonder if you would need to do a 4th treatment, maybe. Yeah, definitely. I mean, again, it's not a one and done, but I am looking at the CRP on top of the overall patient evaluation, and sometimes that might tip the scale in my mind. The patient looks good, the PCV has held, but the CRP is pretty high. So maybe a 4th treatment would be worth it. Whereas if the CRP has almost gone down to normal, it looks like you've got a better handle on the disease, and maybe you can skip and not do a 4th treatment. I don't know if anybody has any experience with that, but I felt like it can be a pretty useful biomarker in some cases. Again, not just looking at a number and having a cutoff, but just integrating that parameter into the overall evaluation of the patient.
I have Cedric. I've certainly used CRP in the IMHAs as well. I've been documenting its improvement over time as a marker that, along with the resolution of agglutination and PCV holding. So kind of collecting the information and kind of using it to point to, hey, this looks, we're doing something good here. I haven't used it necessarily yet to point to whether or not I treat again. But I agree with you. I mean, we do have point of care CRP in our hospital on one of the IDEX point of care platforms, and maybe that is something. That's a really really good thought. I don't know, Erica, have you guys used CRP in any of your clinical cases, to guide whether to give a second, third, or subsequent treatment?
No, we really don't do a lot of cytokine removal. I think for the kind of concerns that were brought up that I'm just not sold on a single treatment. And so I think if we're going to venture into it, either considering prolonged and or repeated treatments. So it's hard to get the rest of ECC kind of on board until maybe there's some better evidence just because of cost, and these tend to be really sick patients already.
Yeah, and they already have like a large bill. So if you had the immunoabsorption on top of it, especially if you're treating like 48, 72 hours, whether it's continuously or intermittently, I mean that bulks the overall price quite a bit. So, but I'm with you. I mean, like if my ECC team would approach me to ask me to do a single treatment on this patient, I probably would say no, it's not worth it. But if you want to do like maybe 2, 3 treatments 3 days in a row. I mean, we can try it, but I'm not sold on the single treatment either. I think we're going to see some improvement. And just like Becky was describing, like, oh, the patient after hour 6, we could like discontinue the pressors, but then like what happens after you start the pump, right? And if they crump again, you just added dollars to the bill without much improvement. Um, so I feel like just like for TPE, for IMHA, I mean, I don't think anybody's doing like one single treatment. We ask them to be on board for at least 3 treatments, so they get like a full dose, and that kind of has been my approach too. Like if we wanted to venture into this type of treatments, I would try to get some commitment that we treat at least 3 days or something like this.
Yeah, I agree. I think unless I have some money to give to the case, it's a really
Yeah.
hard sell because probably our first treatment is $2,000 to $4,000. I don't know. It's maybe we shouldn't talk about money on these things, but it's not inexpensive when you add the device plus the nursing and doctor time plus the catheter if they don't already have one, which they unlikely would. It's just it's a difficult sell for my team until maybe there's better evidence. And for the owner, I'm not sure. If I were an owner, I'd be like, sign me up. My dog that's already on pressors and is septic and maybe already underwent a really expensive surgery if it's a septic peritonitis case or something like that.
And I think that's kind of the problem that we have faced with other diseases like in the past. It's just like as long as we don't have a good understanding of what we are doing and we don't have good evidence to present to owners, it's difficult to ask them to commit to thousands of dollars to treat the patient with an uncertain outcome. And certainly it would be easier if we had some like research funding where we can use for like compassionate care and say, okay, we'll take the price of the treatment until we build more evidence. I mean, it's always difficult to ask people to pay for these kind of treatments when we don't know if we're actually going to change the outcome significantly. I kind of agree with that. But on another hand, it's probably what happened when people started to use TPE for immune-mediated disease as well. Like we maybe we did not know. We had some evidence on the human side and some ASA recommendation, but I think there's also some recommendations about the use of immunoabsorption in sepsis on the human side that we can get our foundation from, but we don't have good veterinary evidence so far. On our end, if we don't build that evidence, we'll be at the same place in 10 years from now. So that's where like I have a hard time like being on that spectrum. Like we should try to do it, but I don't really want to ask people for their money, and I've had a hard time to sell those treatments without more evidence. But on our end, we need to build that evidence. And that's where like research funding is very important, I think.
Agreed. I think though, when you look at the type of funding that is needed, it's just these treatments are so costly, you know? So I think
Yeah.
that if we were to get funding, you know, you'd do a few dogs, it would be like a pilot, and maybe you'd find something. It's so tricky for us, isn't it? And us lowly vets.
But that did at least like give us some information to maybe get a better understanding, come up with a better protocol, and then we'll build from there. But we need to start somewhere for sure. And these single cases, like when you have data, we could look at the data and say, well, obviously that fall or whatever would have needed like a treatment on the next day or something like this. So as much information we can get, we can just like improve the overall understanding on how we can move forward.
Several years ago, I had a funded study, a funded protocol for treating septic foals. And we had the funding, but we couldn't get our equine team kind of on the board, on the stick to do it. But I'd certainly be happy to share that protocol with anybody that wants. I mean, it was a protocol where there was enough funding that you could do multiple treatments. But I'd be happy to share that protocol if I can find it for anybody that would want to use it.
Well, I'd be with that introduction, I can share again and get back to our presentation here, because we actually we do have some funding here at Cornell that again I've been really fortunate to partner with somebody on the large animal critical care side. And so we're looking at both of our friends here, on the Cytoclear and the vet rescue devices are partnering with us in a couple of different ways. I'm just going to skip through some of the background stuff here. But on the carbon side, we've been fortunate enough to get some grant funding from the New York State, the horse racing industry in New York takes a big chunk of the amount that they earn from betting and wagering and the income on that, and they reinvest it into equine research. So we've been lucky to tap into that. And what we've been doing in the equine model, and then I'll share what we're doing in a calf model as well, is running a number of adult horses through basic safety study, running them through the carbon device, the Cytoclear device. And we have 6 or 7 horses that we've performed this on. Again, just normal, healthy horses. How do they react? We're still in the process of measuring and analyzing some of the biomarkers on these guys. But we certainly used it as an opportunity to establish that it was safe without adverse events in these horses, running at pretty rapid blood flows, 350 mils a minute. And because of the sheer size of these guys, 500 to 700 kilograms, we went for as long as we could. We were aiming to try and process 2 blood volumes or so, but some of these treatments ended up being 4 or 5 hours long. But we did establish that it was safe. We performed echoes on them as well all throughout. And really as a foundation to apply for further grant funding, that was the purpose of that part of it. I'm going to skip through this. I want to talk about this is an interesting safety, I guess, element as well. Certainly we always talk about access recirculation in our small animal population as well. I've still got a hold of an old CritLine 3 monitor. And so and a few of the devices to use it. So we did actually run some access recirculation testing in these horses, running at 350 mils a minute with our 14 French 30 centimeter silicone Medcomp caths in the right jugular, and did find that we were not experiencing very significant access recirculation. So that was just a nice kind of side finding in the safety study portion of this investigation. This is the next stage of it. This is actually just last week or so. So now that we've established the safety factor, the next stage is spiking these horses with LPS to induce a septic state and to now treat them again. And in the equine model, we're starting with the carbon, because Kelly Hobbs out of Texas has already done some work in the LPS spiked equine model using the vet rescue device. And I will give a shout out to both companies, both Vet Rescue and Amylogic have been very, very supportive of our efforts in this LPS model. And I'll show you the calf here in a minute. This is the LPS horse before she became clinically affected by it. She did end up laying down and had all the typical changes that you see with a septic equine. But this video was to point out and give a shout out to the folks at Amylogic for creating this extended bloodline set for us. This horse, Juana, did not have a very aggressive colic episode from the LPS. And sometime down the road, I've got a lot more photos and videos to show as well. But some of them can be quite aggressive in their colic behavior. And so we wanted to have some extra length and some extra safety space while we were treating these guys. So this is just to show the extended bloodlines that we used for these guys. We don't have data on the LPS model quite yet, but we're also looking at I should back up here, back to our earlier comments. We will be, comparing the healthy but non-sick changes along with these septic changes as well. In a calf model that we're still in the middle of here as well, and we'll skip past some of this stuff here. We have these are our first two. This is Kansas and Arkansas. They're brothers. These two underwent hemoperfusion, hemoadsorption with the vet rescue device in just again a healthy safety type of model. Both did very well for those, and we learned a lot about anticoagulation strategies, which we're also learning about in the equine model as well. And we've since now progressed with these two. They became their own controls because we then put them through a does anybody remember the last thing?
You were just starting to show the vet rescue experience on calves.
Oh, perfect. All right. I'll bring that back up here. So both studies are fairly preliminary at this point, but interesting so far. We're learning a lot about treating these species. Oh, Cedric just texted. It looks like he had to sign off a little bit early. I think he ended up accidentally ending the meeting for everybody. So I'll wrap this part of it up as well. So very similar to the equine model, we're trying to use the same horses as their own control. So we're trying to use the same horses from the safety study using the cytoclear from the Amylogic team as their own LPS induced septic model. So similarly with these two calves, we established some safety and kind of treatment parameters for them on, just normal healthy calves using the vet rescue devices or the device. And then we went forward and spiked them with LPS again to induce a septic state. And in this second stage, so this was a three-stage. The second stage, one of them we treated with the vet rescue device, and the second one we treated with a sham device. And then in the third stage, we did the reverse. So the one that got the sham in the second treatment, then got treated after being spiked with LPS with the vet rescue device, and vice versa for the two of them. So these two boys have spent the last month with us, getting bottle fed twice a day, getting all kinds of care and environmental enrichment to make up for some of the challenges that they've had to experience with being septic for periods of time. And I'm happy to say that they're both going to a forever home where they're not going to become hamburgers. We have a local person who's adopting them to help train her horses in herding and other calf management practices. But we learned a lot from these two, just from treatment perspective, as well as from anticoagulation strategies, catheter placement, and a whole host of things. Let me see if I can advance here. And this was just a picture of how we were using a clinical scoring system, and we had an independent observer performing the clinical scoring, and we wanted them to be blinded to whether or not the calves were going through the sham or actually going through the treatment with the vet rescue device. So that's what this, I don't know how well this shows up here, but I've got this box over the side of the pump here to hide the device or the sham if there wasn't a device in there, so that they could independently observe and perform the clinical scoring. We also took cytokine levels and other biochemical analyses at different time points, pre and post, as well as the following days. So, while not a clinical case, which are certainly going to behave a lot differently with ongoing generation of some of these markers and some of these inflammatory mediators, we're hoping that as we gather more calves for the study and build the information that we're gleaning from it, that it may help inform some of the practice in going forward in clinical cases. So back to the point that Erica was making, it's hard to get funding for maybe some of these more intensive, as well as there's ethical and other elements from a research perspective on the small animal side. We have been able to get IACUC approval for both the equine model and the calf models, so that we're building up our evidence base to hopefully provide some clinical recommendations slash information to help guide, at least in these species, some of the ways we might implement them in actual clinical cases. This was just, again, I've brought up learning a lot about the ideal strategy for anticoagulation in these patients. This was some of the first sessions we did with the calves, where my anticoagulation strategy of targeting an ACT of 300 to 400 was, as you can see here, obviously not robust enough of a target to prevent clotting, fairly substantial clotting in our circuit. And so with our next treatments and our LPS treatments, we aimed for 500 to 600, and the circuit on the right here was a lot cleaner when we had the higher targets. And that's going to come with some challenges in our, Carolyn's chorea, who is already coagulopathic. And she mentioned the pressures going up in the column. We're certainly going to be challenged with trying to make some clinical decisions around the balance of anticoagulating these guys, or looking at circuit anticoagulation, which, I mean, citrate and the challenges with that in a hemoperfusion device are numerous. So lots to learn, but we're trying to build some of the foundation on the large animal side anyway, and see where we can go with that. Here's the two boys again. The calves do get quite affected with the LPS. They get immediately tachycardic, tachypnic, recumbent. They're quite profoundly affected. Whereas I mentioned our one horse Wana was not quite as substantially affected, but still nonetheless was. So we're taking that next steps for the calf model is to also start the safety study in those guys using the cytoclear device as well. So lots of work trying to build a foundation of clinical recommendations, or at least some information, taking it from the research arena. Getting that out there to the rest of you guys that might be performing these treatments, whether it be in large animal or in other species. This was just Kansas here, getting his safety study with the carbon device, and we'll keep going with that side of it as well. It's an ebb and flow of research supports and financial supports, and I don't have that going on the small animal side to this point. But maybe there'll be some crossover, or maybe this will form some evidence or some argument for some support on the small animal side as well, and we can grow that together. And if anybody is looking to collaborate on any of these species investigations, feel free to reach out to me anytime too. And we've got a couple minutes left, so I've been doing all the talking for the last 10 or so. Any questions or comments on any of this stuff, be happy to entertain them. And again, a big shout out to both of our collaborators on the vet rescue side and the amylogic side. Can't do any of these things without some really substantial support from those guys. Carolyn keeps promising she's going to come over and visit us during one of these sessions. The welcome mat is always out there for you.
I'm making plans.
We were going to try and do another septic horse this week, but our schedules didn't align, and ACVNU is coming up, so large animal colleagues are heading to that next week. So we're still probably a couple weeks away from our next LPS equine treatment. But again, I mean, hopefully this isn't quite the, the control from a septic sick patient treated with hemoperfusion and hemoadsorption compared to a septic sick patient who's being treated medically. But maybe from the research side, at least we've got a control and a treatment group, and that'll build some foundation of evidence to help guide some clinical applications. Dr. Calgill, I don't know if you're still there in the background. Any of these, I know I didn't go into all the details of the research model and all the rest of that. Were these syncing with some of the work that you had done previously or had been thinking about?
Well, unfortunately, we didn't get any work done, but we had an IACUC approved protocol, had funding from, we have a similar situation at the, UC Davis where we get a certain percentage of the parimutuel bedding industry, and that comes back for equine research, and that's a pretty lucrative pot. And one of the co-investigators on the project was head of that research pot. So, but I just couldn't get the equine group. They were, they were really interested, but they just wouldn't get their act together and get going with it. So eventually the project didn't get funded. We held on to it for a long time, and it just wasn't going to go. So I gave up on it. But believed in it. The other good thing about the septic foals is there's a lot of I think that's a great model because that disease, from my perspective, is very, very consistent in terms of clinical presentation, and there's a lot of good documentation on it. So we had actually proposed to use historical controls as the controls for the patients that, if we change the morbidity and mortality in treated patients versus the historical published data for that disease, we thought that we would see enough benefit that we could document that statistically. But I think it's a good model for identifying whether these devices and cytokine reduction would have an impact. I think that's I think the septic fold model is a good model.
Well, with that, we seem to be up against the hour here. For those of you guys that signed back on after we got kicked out.
I might just also say that we did for the foals and for these newborn animals, we did the same thing. We brought them up to our unit, where we have more control. One time we had a little area. We have a neonatal intensive care unit for the equines, and so the mares can be, in eyesight and whatever. And we'd take them down to let them nurse periodically. But most of the young foals that we've done up in our small animal unit.
Yeah, this was one we didn't. I alluded to it, but didn't get any further into it. This foal was a little bit larger, and so and the mare was quite protective. So this was one that we treated the 3 times, and we treated her in the ICU, the equine ICU, which certainly back on the control aspect had a lot more challenges to it in terms of cleanliness, and the mare would reach over, and this was my view. I was down next to the foal on the ground most of the time, trying to prevent her from slobbering onto the catheter and the extracorporeal circuit. And meanwhile, she was dripping hay and water down my back the whole time. So certainly, yeah, the control aspect becomes a challenge when you're not in your usual abode. But makes for interesting and a little bit of a fun time out there. All right. Well, Carolyn, thanks so much for sharing about your career. I'm sorry the outcome wasn't where you were hoping to get it to, but I'm sure you guys learned a lot from it and helped us learn as you shared with it. And Serena, thank you for introducing yourself and sharing a little bit about the practice there in Italy where you guys are at. We look forward to seeing you on here more, and excited to hear about some of the work that you guys are doing out that way. As always, Dr. Calgill, we stand on the foundation and on your shoulders for everything you've put towards this veterinary community of extracorporeal therapy providers. And our folks at Vet Rescue and Amologic who both join in here, and the Dr. Bode and the team at Tufts, and everybody else that signed on, Dr. Reinecke, who's not with us still on the call, but the folks at Penn and everybody else that contributed today. Really appreciate it, and look forward to seeing you in a couple of weeks. Same time, 11 a.m. Eastern time. Same place, same Zoom link, and we'll talk more about Renal Week so everybody can start planning for that coming up next April. And between now and a couple of weeks, hope you guys all have success in whatever you're up to, extracorporeal therapies or otherwise. And hopefully we'll hear some fun stuff when we meet together in a couple of weeks. That, take care, and happy Friday.